Thank you very much, Janice, and everybody. It's great to hear your descriptions of some of the things you've got up to yesterday. And sincerely, thank you for including me in this global conference, thinking about how we can approach pain with maybe renewed energy to bring hope and help to those who are suffering. So, yeah, I've been a GP for a long time, and we are trained very much in a biomedical model. And of course, the biomedical model has a lot to offer chronic pain as any condition, and will always be an essential part of what we bring as clinicians. But I have learned that actually the clinical story is probably 5 or 10% of a person's whole well-being. And the last 10 years of my life, I've been very privileged and excited to stumble upon social prescribing. So that's acknowledging the social determinants of health in addition to the biomedical ones. And of course, you will be able to reel off a long list, I'm sure, of unemployment, isolation, housing, poor diet, immobility, difficult relationships, substance misuse, depression, generational patterns of behavior that just continue, toxic cycles. Certain neighborhoods, certain cultural backgrounds may actually predispose towards poor health and what Sir Michael Marmot calls learned helplessness. Because when things are tough, you can give up feeling that there's any possibility of them improving. You can reach a point where you think, well, this is my lot, and I'll just have to make the best of a bad job, but it's always going to be a bad job. And this learned helplessness means that you may dip into a system to get some help, but it doesn't change the helplessness. And our system tends to respond to helplessness by providing maybe just that bit of help that's needed for that moment, or even the bit of help that is perceived at that moment. And then that help has gone, and that helplessness is still there. And helplessness leads to hopelessness. Why bother? Why expect any change? And in fact, it's quite difficult to engage people with physical health conditions in improving their lifestyle, their diet, their exercise, if actually they've very little reason to be getting up tomorrow, let alone in 10 years' time. Thank you very much. And as a clinician, I have looked into the empty eyes of people where I have been using my medical tools to try and fix them and make them better. And to be all honest, in all honesty, I've missed the mark, because that which has brought them in, probably repeatedly, wasn't biomedical all along, or it's so heavily laden with the biomedical, with the non-medical, that I need to start acknowledging the social determinants before we're going to get anywhere. People with chronic pain and chronic long-term conditions can get into a rut of not caring for themselves, having no self-esteem even, feeling nobody cares for them. And that negative kind of mindset doesn't enable them to be motivated to connect with solutions. So we end up with a system that is not helping them prevent any of that. It's just plugging the gaps. It's not really working upstream with them. And you get these awful cycles of pain, social health determinants, more pain, more social health determinants, more hopelessness, less vision, less hope, less connection, less finance, poorer housing, and on we go. Social prescribing puts a pause on all of that and says, do you know what? Let's park the biomedical for now. We'll talk to your doctor if we need to, but let's get to know you as an individual. Let's understand not what is the matter with you, but what matters to you, what your strengths are, and chip away at those years of feeling cynical and let down to let a little light in, let a little good news in, start to grow some hope and some possibility. And well, what might a good day look like? What could we possibly start to change? So the model of social prescribing is critical upon a link worker, an individual who can get to know that person. Now, that can't generally be the healthcare worker, although some healthcare workers can certainly add that to string to their bow, but it's not really for doctors to spend a lot of time doing that. So it's for us as referrers, anybody as referrers, to introduce a person who may benefit from a social prescription to a social prescribing link worker who has time, as I said, to get to know somebody. And bit by bit, the social determinants of health will pop their heads up. Sometimes you don't see the big ones straight away because there has to be trust before a person will share all of the things that are going on in their life. Quite often the clinician won't spot the big ones. They'll just have a sense of there's definitely something else going on here. I think in addition to what I can do for you, you would benefit from this conversation with a colleague of mine. Now, the model that we have in the UK basically allows maybe 6, 9, 12 contacts of maybe an hour to start with, maybe half an hour, quarter of an hour, dipping in over a period of 6, 9 months. And the personalized care plan aims to connect in to that individual's life other organizations, community organizations that can offer different things. Now, there might be some mobility needed. There might be housing problems, might be debt advice, might be relationship advice. Somebody may be burnt out as a carer. Somebody may suffer post-traumatic stress disorder on account of having served in the armed forces. And we're finding social prescribing reaches out to veterans and all sorts of special populations. There may be people who are disadvantaged ethnically, who may have got stuck in a rut, and there may be some particular kind of reach out to them, which enables them to explain their social health situation and enable the link worker get to know them, start connecting them with the right advice, the right community groups, and gradually a different kind of life starts to emerge. Now, what we found in the UK is our model will translate into most other kind of societies. And also working with Canada, what I found was that there's a lot going on in the community. And actually the model was very readily welcomed because it simply gave a bit more of a focused conversation about linking an individual to the already waiting community groups. Obviously, then you've also got to think, do the community groups have capacity? And this whole social prescribing makes us think about social capital and the way that we invest in our community groups, so that an individual has enough wrap around them to help them journey into a different kind of future. So you start to develop some hope, some vision. You start to develop some problem-solving skills rather than an obstacle adding to another obstacle and another challenge. You start to see some of those problems as possibilities, and the coaching approach of the link worker enables somebody to start reframing their can't do's into, well, maybe this is a can do with a different kind of help, with a different kind of approach. maybe connecting with a different group of people might do more than one thing. The lady that was mentioned in the introduction found community as well as craft. People will go on healthy walks and discover friendship as well as exercise. People may end up volunteering and discover work. I've had people do that, and that's just incredible. People you never imagine would get back into work, but because of the social prescribing approach has started to enable them to take an interest. There's been volunteering opportunities which have then connected to other things and have led to employment. So it's not just self-care, but actually giving back into society, setting up new behaviors, new habits, shifting the mindset. And all of this, of course, changes the way the system starts to work. Because, as I said, generally our system is very reactive. You know, we're planning to try and sort people out in crises and put the money at the front end of A&E, etc., etc. Whereas it gives us a bit more of a sense of what we could invest in upstream to prevent some of this, what we could do to actually build some resilience and some possibility within our communities, so that we're thinking ahead and giving people help before their mental health, their pain, their whatever gets so bad that the only place they feel they can go is an accident and emergency department. It starts to change up the way people eat, the way people are housed, starts to give them new friends. Now, all of these things will make a difference to pain, inevitably. If you're facing pain on your own, it's going to be very different from actually having a community that care about you. And you may well best not talk about your pain necessarily, because you've got something else to talk about. I've heard a lot of people say that once they stop rehearsing their pain has actually got less of a hold on themselves. And the reality is, if pain is the dominant feature in your life, it is going to dominate in conversation. It's going to dominate in relationship. It's going to actually have a real grip and a real control. Whereas what we want to do is give people control of their lives back. Now, if pain is an aspect of that, so be it. We will find every way we can to diminish that. But let's actually park that and look at you, because your pain does not define you. You are a unique individual with possibilities and skills and dreams and ambitions. There are possibilities that a social prescribing kind of conversation will start to unlock. And that reduces the pain. It reduces the consequences of that pain, because actually it's not quite so isolating. It's not quite so oppressive. It unravels some of the complexities of pain, because actually I'm more interested in something else, in this craft I'm learning, in this group that I've joined, in the fact that actually I've got better access to my community and I can get out and get around and be more a part of the society in which I live. It reduces the hopelessness. It improves the mental health and thereby reduces the depression. And it opens the door to more life. And this is just critical. So what we are finding in primary care in the UK is that social prescribing is reducing the number of attendances in primary care. It's reducing the number of attendances at A&E. And it's starting to bring the voluntary sector round the tables of commissioning and decision-making more than they've ever been before. And because community agencies are generally commissioned in a rather short-term manner, it's actually challenging our thinking in commissioning. Because if we are to enable communities to be there increasingly for their members. We need to ensure that their organizations are sustainable. We need to invest more in them so that they are able to deliver the services, which are the prescriptions that our link workers are going to make available. So it's really changing the conversation, and it's a catalyst for transformation for individuals, for agencies, and for whole communities and whole systems. We've got a new unitary within the UK called the Integrated Care System, and they comprise between 8 and 12 maybe primary care networks, which are groups of general practices which serve between 30 and 100,000 population. We're kind of bunching ourselves differently, and the integrated care system is an opportunity to start to look at how we use our resources between acutes and social care and voluntary sector and local government. And actually it's giving us an opportunity to look at the way money moves about, take down some of those artificial silos which put in perverse incentives and mean that we waste money in the gaps, as it were. And it is a dawn of a different kind of thinking. That said, of course, with cost of living crisis and lack of capacity in every aspect of every agency, we still have a fight on to get people to think upstream, preventative, personalized, transformative, enabling. And we have the challenge on to increase our workforce of social prescribing link workers sufficiently so that we can refer people in, and they really do have that opportunity, maybe for that once in a lifetime. You know, you matter, and we are going to look at you as an individual, your possibilities. We're going to look at what it would take to motivate you, how you would like to be connected. We're going to look at potential that maybe has never been recognized, and we're going to start to change that for you. As I said, that will, the sense of hope and excitement is immense. And I have to say, patients that suffer pain are really benefiting from this. You know, they'll just come to life when you start changing the subject, not just talking about their pain, but you're recognizing them as an individual. I was talking to one of my patients just last week. She has chronic pain. Goodness, she has had for, must be a good 10 years. She's also deaf, as is her partner. And her access to anything other than her world of pain and difficulty is limited also by the fact that she is completely deaf. But we started to venture out in our conversations last week, and I have connected her with a local craft group who will be able to work around the hearing challenge and will be able to start bringing her into the group and including her in craft activities and in craft communities. Now, this lady could not wait to join the Facebook group of this particular group. Even during the consultation, I was able to show her that. So actually, in this amazing little connection, she probably doesn't even need a link worker. I've done that myself. It doesn't often happen that you can jump straight in to a new world with new possibilities. Often I have to broker the relationship of trust between my patient and the link worker. But you see, it's just about seeing a person with possibilities rather than seeing the person in pain and thinking, I guess I'm going to have to up your opiates because you've become more tolerant. The fact is, when this lady has something else to think about, I would have a much better chance of reviewing her medication and conquering sufficient of the physical side of her pain for her to be able to enjoy her life. And her husband was so excited to see on her face that she was looking at something else. So there was another possibility in the room. So you can bring this into every aspect of your care, wherever in the globe you are. We're talking to people all over the world. It doesn't matter what your health system, your voluntary sector looks like. It's just about looking at things differently and seeing people as individuals, seeing people with possibilities. I remember I was talking about this to another gentleman, again, chronic pain, and I started talking to him about the concept of social prescribing. He was fascinated, and he said, "You mean you're giving me an escape map out of my prison?" And it's a bit like that, isn't it? A personalized plan with groups and activities, resolving maybe debt by conversations with people who can manage that, so they're paid off a little bit of it at a time and not feeling burdened by the impossibility of it. Whatever it is, dealing with addictions, dealing with hoarding, dealing with maybe secret things like not being able to open their post and actually being about to get evicted because they hadn't noticed some very important letters. Social prescribing will reach all of this, and it will coach individuals through to a place of seeing a challenge as just that, not an insurmountable problem, but let's get you the help you need to get round that. Let's move past it. Let's move to possibility. Such a relief for the families and the carers of people who have been so despondent and so sort of in a bit of a side eddy, really, while the rest of life rushes past. It acknowledges the value of each precious individual. And the reality is, this is population health management, one precious, unique individual at a time. It's looking at things with hope and vision. It's like a stream in a desert. It's like a breath of fresh air. Honestly, in 35 years of primary care, social prescribing is the most potentially transformative initiative I have ever been able to offer my patients. I'm not just fixing things. I'm not just trying to squeeze something into a biomedical model and see if I can make it work. I'm not now just overlooking maybe something that is actually a social issue that has been somatized because we have trained our patients to come with physical symptoms. I'm not calling something mental health when actually somebody's just crying out for help, to be acknowledged, to work maybe through generational lovelessness and lack of worth, to have a sense of self which is creative and possible. And it really is making us have very different conversations across our communities and showing us where we need to invest so that everybody gets a chance. We're working at cradle to grave social prescribing. We're working on social prescribing that reaches anybody that may benefit from it. And I'd encourage you, wherever you are, to think, can you connect with it? Can you start it up? can you carry this flame? Can you carry this flame into your pain services so that you're not just looking at pain, you're looking at purpose, possibility, a truly personalized care approach, one unique, precious individual. You're going to reduce pain more than you ever thought was possible. Thank you. Now I think there might be some questions.
Yes, there is. Thank you very kindly for that really stimulating conversation that you just, or talk that you just had. I think that other speakers in the last couple of days had hit some highlights, but it's a really interesting model that you've got in the UK. I'm curious, did you cover, are these social prescribers healthcare workers, or what kind of training do they need to have to do this work?
That's a brilliant question. Do you know, I'm privileged to recruit them as well as train them and all the rest of it, and supervise them. Do you know the background is not mission critical?
True.
What you want is somebody who's been able to see that second mile and not been able to go there. You want somebody who is able to span boundaries and to have conversations, who doesn't consider themselves in a silo, but can actually have those conversations across the silo with the individual in mind. Because sometimes they need to be a little bit of an ambassador. Sometimes they need to be a bit of a warrior. Mm-hmm. You know, they have some jobs to do, these link workers, but they are bearers of hope and possibility and determination. And I'd say really it's about their characteristics more than their competencies. They can learn all sorts of things, and they can also share learning between each other, which they do very much. Solution finding, problem solving between themselves. You know, they won't ever just think of it with their own heads. They will involve others and lots of resources.
Yeah. So good life skills, really.
Oh, yes.
Yeah. Okay. I'm just going to read. So sorry, my eyes will cast down for a second. Do you have any tips or suggestions on how to assist those who have social anxiety or poorly developed social communication skills and who have historically had difficulties in connecting in social situations?
Well, do you know, the pandemic gave us some other ideas with this, because it opened up the virtual world, and it's possible that the virtual world may be an okay hook for somebody with social anxiety, that the link worker may be able to work with them to join something virtually and then potentially walk them down the road, as it were, to the group. You know, I think we use relationship, we use little by little, but once they start to get to do something that fascinates them, they will get over it. I mean, often creative things, or photography, or getting out, you know, in the greenery, you know, there's lots of different things. If you just about approaching somebody with something that doesn't make them feel quite so anxious, and start build on that. But this is what the link workers are good at. They will find that little safe space to start growing.
Right. I really like that whole seeing the person with possibilities perspective. I think that's something I'm going to carry forward. I really like that. Excuse me. Any suggestions for developing social connections across greater distances? Well, again, you just answered that really virtually, but okay, we have many folks living in remote areas, and sometimes healthcare providers may fly in for monthly clinics, and they have, and they may not have internet. How might patients in remote areas broaden connections?
Right, that's a challenge, isn't it, really? But generally, you find in remote areas, do you not, that there are people that are resourceful, and you need to find them in your communities and probably connect with them as community connectors, so that your healthcare or your social prescribing workforce knows who to call on in that community. it's about using who's there and find who's got the heart to make the difference.
Yeah, I agree. And there's often a lot of social or opportunities to be social, right? So I think it's just linking them with some of those community resources. Okay, last question is, how are you finding the reception of this social prescribing in the broader medical community?
First, it was a little tricky, but the NHS England decided to push it right into primary care with the primary care network link workers. So it's given everybody a bit more exposure of it. The reality is, when any medical person starts to hear the stories that their patients tell them of how difficult their lives are, their hearts melt, and it does reduce demand upon us. It's just about stepping out on the water and believing that somebody who's not medically qualified might be the right person for your patient.
Right. And that's a beautiful way to end. Thank you again, Marianne. That was a very stimulating conversation that we've just had with you.